Thank you. So, so let's go back again. So the idea that it's a upper bone to lower bone contact in centric relation gives the thinking that because it's a hard relationship, hard tissue to hard tissue relationship, that it should not change much. And because of that, that they think it should be a pinpoint accuracy and that they can transfer that to the articulator through the one that you read about either pantographic tracing or Facebook and so forth that we'll talk some more later. Okay. And I am not here to argue that that's a completely wrong idea. It is actually, it has a tremendous value in our evolution of understanding. But from a clinical dentistry perspective, you need to, I'm going to get to the point where that centric relation is a range, not a pinpoint. And where that comes in is the notion that there is always a reasonable thickness of disc in there, and that there is going to be ligament, if not the muscles, that will hold the lower jaw against the upper jaw. Okay. And so I keep emphasizing that because so much of the dental literature evolves around this idea that it is a pinpoint accuracy, pinpoint accuracy. Okay. I certainly don't want anybody to think that centric relation is when somebody's jaw is way out there. No, of course not. But within a reason, once you get into the within reason, those of you who had listened to my lectures, you understand that I say that it's somewhere around 1 millimeter to 1.5 millimeter anterior medial lateral range, according to the literature. Okay. And that range primarily comes from the suppleness or the flexibility of of the disc and the ligaments. Okay, so we have to drill that into our head when we have this understanding of centric relation. Okay, because that's what's gonna give you the confidence later on as to how you approach people's clinical occlusion. Okay, now he has. I'm gonna start out with chapter 8, adapted centric posture. Okay, and and um, and um, I want, it's a short chapter. Um, it's important that you know that we have understanding that people do not come into your office or my office telling me whether they have a good centric relation that's not damaged or that they come in with adapted centric posture. Now you notice how how that he's now using the word not only adapted, but he's using the word posture. He is not saying it's an adapted centric relation. He is saying it's centric, adapted centric posture. Okay, and so one thing that I wanted to say, the way that I have begun to think, that has been very helpful for me in my evolution of understanding of centric relation. That is that instead of thinking that it's a relationship, because that we think like it has to stay constant or this or that, okay, I tend to think of it as a position, centric relation position. It's so kind of like, I'm not trying to split the hair. I think that kind of gives you an idea. Okay, well, that can be accommodating the concept of posture. That can be accommodating the concept of relationship, relation. Okay, it is some sort of a position that is useful for us. Now, whether it's a healthy position or a adapted position, when I say healthy, it could also include adapted position. Okay, how about if I say physiologic position? Okay, that allows all that upper and lower jaw bone to be functionally stable as it functions throughout the day and year in, year out. When I use the word physiological versus pathological, right? We say something is pathological because it continues to break down. It is not healthy. It's not sustainable. It's not something that's going to be stable. If we use the word adapted or healthy, I'm going to bring it all together and say that it's a physiological relationship. Okay? Because in clinical dentistry, let's be honest, as we see our patients, majority of our patients are somewhere in the between perfectly healthy and adapted relationship. And the reason why I say that is because now, as we delve into it, he talks about he talks about how when you mount the CR, the relationship on the cast on an articulator, he talks about how you have a initial contact point that forces the jaw to slide into the lack of better term, maximal cuspation or centric occlusion. And when you're doing that, he's saying that the joint is getting out of its posture. Okay. Well, let's be honest. So many of our patients have that. So many of our patients have that. Okay. And and even though I do, for the most part, agree with Dawson's shall we say, perspective of having to that our patients require healthy the healthy joints, physiological joints require the coinciding the same position of centric relation position and maximal cuspation position to be same. If we were to practice like that for all of us, including my practice, we're gonna have run the risk of getting accused of being a quack because we're gonna end up doing occlusal equilibration on every patient. Okay, and that is something that we have to be careful. Even though I do think that is the best position, all because we live in a society where things are not perfectly understood by everybody. Okay, and even though you are a doctor, you are licensed, and you practice according to how you have learned, the concept of the concept of standard of care sometimes kind of holds you back because there is so much disagreement about this in dentistry, okay? And that we are not going to be able to say the first thing we want to do when the patient comes in is to equilibrate their bite. I know that there are people out there doing that, but they run the risk of running into trouble with standard of care. Just because the standard of care means what average dentist will do in your community. That's what standard of care actually means. Standard of care is different than what the dental school taught you by every discipline. Okay? Because dental school says, as a general dentist, you need to be able to do everything if you're going to do anything and everything, you have to be good enough to practice at a specialty level in that particular discipline. But the reality is general dentists can't do that. And the standard of care, because I used to be part of the peer review board, I used to testify in court for malpractice cases, and I had many different discussions with lawyers about this. Okay, standard of care means what a reasonably well trained dentist in your community is able to practice. Standard of care is different in LA than in, let's say, I don't know. I'm gonna try to come up with some, no disrespect, but really rural place in the world. Um, like, just to make it like really disproportionate. Standard of care is different from LA than, let's say, 3 hours north of Fairbanks in Alaska, because over there you have no specialty. You know, the law does not require the dentist to become perfect. Okay, it does not mean that we can be sloppy, but what it means is that, one of the analogies that I always shared in my lectures is that whether you agree with my analogy or not, I remember when I was young, when BMW was first starting to become vogue in America. Uh, they had this advertising on TV where this guy, I believe it was a theory series, and he's just driving like a madman, initially on a racetrack and then on a mountain road. Um, and they're talking about all the great things what this car can do. Um, and then toward the end, he goes over a hilltop and he has to hit on the brake because there's traffic jam on 405. It doesn't matter what your car can do. When you're in a traffic jam, you can only go as fast as what everybody else on the road are doing, right? And sometimes that's what our practice is like. And so to a certain extent, you pay that really nice car for your own enjoyment, not because you're going to go on a racetrack every day. And to a certain extent, that's our practice. At least that's how I feel like our practice is like. I practice the way that I do for satisfaction of my relationship with me and my individual patient. I try to provide the best care that I can that my conscience allows, right? It's not because I'm trying to keep up with Dr. Jones down the hallway. My goal is to become better than Dr. Jones, knowing what the community standard of care is. Okay. And when we start talking about the CR, it is beginning to delve into that. So it's important that I share with you the what I know and what the book is saying. But at the same time, I also want to make sure that you don't get in trouble and that you are able to still practice at a level that's going to be satisfactory to you and your patients. Okay, so let's go to page 70 in the book. Okay, that's the beginning of chapter 8, adapted centric posture. Okay, so on the very first page, top of the left-hand column, he starts out saying, centric relation is the accepted term for defining the condylar axis position of intact, completely seated, properly aligned condyle disc assemblies. I don't have any problem with that. A TMJ that is structurally deformed with a misaligned or displaced disc cannot be described as in centric relation because it does not fulfill the critical requirement of a properly aligned disc. However, some structurally defined temporomandibular joints may function comfortably even though they do not fulfill the requirements for centric relation. A wide range of intracapsular structure structural disorders from partial to complete disc derangements with or without reduction may adapt to a uh, conformation that permits the joints to comfortably accept maximal compressive loading by the elevator muscles. Until the term adapted centric posture was introduced, there was no accepted terminology to define the condition or position of such joints. Okay? You know, going forward, I am going to challenge you, as long as you're not overly exposing your patients to radiation, uh, when it's appropriate, when you know that the patient can maximize their insurance benefits, get into the habit of getting panoramic x-rays for your patients. And when you start doing that, you start looking at the joints. If your panoramic view does not include joints, that means the assistant who's taking the panoramic x-ray is not positioning the patient properly. You have to get a reasonably diagnostic image of the TMJ as well. When you do look at the TMJ for your patients, what you're going to start to realize is that a very large number of them, I'm not going to say majority, but a very large number of them have discrepancies of the shape and size between right condyle and left condyle. The positioning is going to be different, and you can immediately start to see some people have what's clearly visible space between the eminence of the upper jaw and the condyle of the lower jaw, meaning that there is probably reasonably healthy disc space there, to people who do not have such space between upper and lower. You will see the right condyle becoming bigger than lower, or left, or vice versa. The left condyle is becoming smaller compared to the right. Now, I am not here to say that panoramic X-ray in any way is definitively diagnostic. No, you would have to rely on MRI, and MRI for the disc, and then the CT scan for the condyle itself. But you can get reasonably accurate clinical impression from panoramic X-rays. And when you start seeing that, you realize that, but majority of those patients do not complain of joint pathology. And I'm going to have to say, according to what Dawson's saying, every one of those patients with whom I see condylar size shape discrepancy and the TMJ joint space, the disc space discrepancy, to be having this adapted centric posture. Okay, and you realize there's so many of them out there, you can't really clinically treat them differently. You have to treat them the same. And the reality of it is, a lot of times we never take panoramic X-ray on them, so we have to treat them as they come. So, and if you read Dawson's this chapter, essentially what he is basically saying is they may look the same, but if it quacks like a duck, treat it like a duck, right? You know, I don't care if it's a goose that's among the duck. If it's acting like a duck, we're gonna have to just treat it like a duck. So, and then a lot of times some of my patients will come in with actually a previously questioned or diagnosed TMD, temporomandibular joint disorder. And I would usually go by just a panoramic because that's all I have in my office. And then and some of them or other people will like question me or challenge me. Well, Dr. Lee, don't you need a CT scan and then the MRI to come to a official diagnosis before you move on with how you want to manage them? And I'm going to be honest in saying that, well, if you're truly looking for academic diagnosis, yes, you probably need that. But guess what? It's still not going to change how I'm going to treat them. It does not really change. I'm going to say about 90 to 95% of the patient population that I've seen in my career, if not more, close to like 98, 99% of the patient population. And I treat a lot of patients with occlusal problems. Okay. There is no difference in how I approach, how I treat them. Okay. How I can come to the conclusion whether they have a some adapted centric posture, I know that. It does not change how I treat them. So what I'm trying to say here is don't get hung up on somebody has perfect centric relation. Somebody has adapted centric posture. Don't get hung up on that. Okay? What's important, what's important is what's clinically relevant. Okay? What's clinically relevant is going to be what Dawson says is healthy joint, predictable joint. Okay? So let's take a look at um, uh, just to do him justice. Let's just take a look at this here. Let's go down a little bit. Third paragraph on the left-hand column on page 70. Okay, he says many TMJs function with complete comfort and apparent normalcy, even though they have undergone deformation caused by disease, trauma, or remodeling. Some TMJs click or exhibit other signs of intracapsular disorders, but they do not prevent patient from functioning in an acceptable and comfortable manner. Whether a TMJ is in adaptive centric posture is based on whether it can comfortably accept firm loading and whether it is manageably stable. So basically, he's saying the same thing that I'm saying. And then thus, he says, adaptive centric posture is the manageably stable relationship of the mandible to the maxilla that is achieved when deformed TMJs have adapted to a degree that they can comfortably accept firm loading when completely seated at the most superior position against the eminentia. Well, the only thing that I will change, as you know, is not most superior position. We're going to have to constantly remind ourselves most superior anterior. It's sort of like 100% perpendicular, 100% horizontal. I'm going to say, for the lack of better description, I want my condyle at something like 45 degrees or something like this. It is not purely the superior. Just because, as his drawings demonstrate, that's where the disc is positioned. And if the disc is positioned there, that's where I want to be able to load my joint. Okay. All right. So, uh, I think, I don't want to keep the same thing repeated over and over. Okay. So I'm gonna just say whether it's because of the, as he says, lateral pole disc derangements. Okay, derangement is just a fancy word that it's not normal. Okay, on page 71. Okay, or that there is a when we say derangement with the formation of a pseudo disc, meaning if the disc is completely displaced out of its position and there is a fibrous tissue that is forming to keep keep the upper bone and the lower bone from directly contacting each other, and that can be considered acceptable as long as they don't have pain. Now, if the disc is completely out of its position, they are more likely to have pain. Okay, but many times it can be adapted to the point where they no longer have the pain in that area and becomes functional. And we think it's because of this um, pseudo disc that forms itself. So, so if you were to look at the pictures, because pictures speak thousand words, on page 71, figure 8-1, he's sort of showing you at least A and B, that you have a reasonably healthy relationship. I'm sorry, uh, the bone to bone, the B one, right? And the A one, lateral pole, he says is a disc that's out of its position. So I think I mentioned this to you once before, that is the disc wraps around both when we are looking at it from the lateral, okay, the disc looks like it's out of its position, but when you get to the medial side, meaning towards the center of the skull, okay, that they are still held in its position, okay? And so you have to think about the disc in three-dimensional way. That being said, in figure 8-2, when the disc starts to become really, really out of its position, what he's saying is that there is painful compression of retrodiscal tissue when the disc is completely displaced. Now, when the disc is completely displaced, then eventually, okay, you come to figure 8-4 in figure 7, page 72, where it becomes bone-to-bone contact. Now, another situation where this becomes an issue with patients who suffer from osteoarthritis or even rheumatoid arthritis is that they still end up having bone-to-bone contact. And it can become extremely painful for them to do any kind of clenching or chewing. In my career I don't want to tell you how long I've been in practice, but I'm going to say it's been probably less than 20 people, somewhere between no more than 10 to 20 people that I would say who arguably met this requirement criteria where they truly had no disc or even pseudo disc. They had true bone to bone contact where they were in constant pain upon any mobile movement of the disc. Okay, so it's extremely rare. Okay, and I think part of the reason, even though we run into a lot of people who suffer from arthritis throughout our body, right? They talk about hand, they talk about the hip and the knee and all this and that. I think one of the reasons why we don't suffer from classic arthritis in the jaw joint compared to many other part of the body, not only is our jaw joint exceptionally well designed and has a very tough disc-like meniscus, but because we constantly, if you think about it, we constantly move our jaw. Not because we're constantly eating, but because, like me this morning, I'm going to talk like crazy for the next 2.5 more hours, right? And when I'm talking, this constitutes, for most of us, more of our jaw movement than when we are eating. And because our constant movement and talking, we don't really load the joint so much. It's a great form of physiological exercise. Okay? So, and this, I'm going to give you a hint. This is why phonetic testing is so, in my humble opinion, so critical and indispensable. And I hope you picked up on that when you've been reading these chapters for today's session, because phonetic testing is really the underappreciated method that we can use. Why? Because we spend more time talking with our jaw, with our teeth, than actually eating. And with the only exception of, I would say, people who constantly clench, okay? And that presents a different set of challenges in satisfying the requirement of how the teeth come together when we talk. That's why it's so important. because we spend more time for most of us doing that than anything else with our jaw. Okay, so it is um, important that we just accept the centric relation as being a range. Just because he spends so much time talking about joint derangements and joint pathology, and we're about to get into that a little bit later also, right? Okay, it is important that you recognize, especially as general dentist. I'm not trying to write you off and saying, yeah, you're a general dentist, you don't need to know this. What I'm trying to say is that majority of our patients, 95% plus of our patients, okay, are well treated by just thinking about centric relation and adaptive centric relation, thinking that they have reasonably physiologic TMJ. Okay. Now, important thing that I wanted to emphasize here, okay, is page 73. Okay. Oh, okay. I'm sorry. Before we get there, it just because I outlined these things and it just comes to me. So page 72 on the right hand column, on the right hand column, okay. Um, so let's just start with the halfway down, other partial disc derangements and clicking TMJs, because we do run into a good number of patients who have clicking joints, right? Popping or clicking joints. So let's talk about that. Okay, the first paragraph under that subtitle, it says, reciprocal clicking is always a sign of damage to the ligaments that tether the disc in place. A disc cannot click if the posterior and collateral ligaments are intact. I'm going to say, I know what he's saying. I'm going to say, actually, the disc will click if the TMJ joint is deformed. If he wants to say intact, intact and deformed, if you're going to say that if it's intact means that it includes that it's not deformed or whatever, there are some, shall we say, room for us to play with the words. But I'm going to say this: it means that it is the disc can be slightly deformed, and that will cause the clicking noise. Why? Because when your condyle and the discs interact with each other, if your bone or the disc is slightly deformed, it's not going to be a smooth ball rolling or like this. When instead of a ball doing this, if there is a lot of uneven surfaces, they're going to go up and down, up and down. And that's what clicking noise is. Popping means your disc is either partially or fully getting in and out of its position, right? But clicking noise is because either your condyle bone is no longer smooth round, it's got, whether it's arthritic or it's becoming flattened, whatever it is, that the bone is not rounded even. And then you can have a disc that's not smooth surface, or it got really, really thinned out because of the clenching. So your bone to bone becomes more noticeable. The disc is no longer able to cushion it. That's why you have the clicking noise. Now, what I tell my patients when I treat them, I tell them I don't treat it so that your clicking noise will go away. However, if we have predictable good occlusion, popping noise and clicking noise will eventually get less, if not completely go away. Why? Because we're creating an environment where where the disc can heal itself, can become physiological again. Okay. Okay. So, you know, I'm just going to continue reading the book. The variations in deformation of the ligaments and disc appear unlimited. Yes, You can have all kinds of different variations of this. Okay. However, many clickings and deformed TMJs have adapted sufficiently so they can comfortably accept loading. Okay. Now I'm going to go down to the next paragraph. There is no difference in the procedure for determining either centric relation or adaptive centric posture. There's no difference in how you figure that out, where you're at. Both should be confirmed by load testing to verify that joint is completely seated, by load testing to verify that, I'm sorry, I'm reading the same line again, and the lateral pterygoid muscle is released. What is different is that deformed joint that has adapted to a comfortable capacity to accept loading is not as stable as an intact TMJ. So patients should always be advised in advance of any occlusal treatment that there will be a need for periodic occlusal correction to maintain harmony with the changing joint position. Nevertheless, it is a manageable condition, and if the occlusion is meticulously corrected, follow-up corrections usually require only minimal changes. So here is what I'm trying to say to you. And those of you who have listened to my lecture before, I've said something similar. Remember I said that if we treat somebody who has had previously bad occlusion, and when we treat them, whether even if it's only with a simple filling, many times with single crowns, sometimes with, many times actually with, quadrant dentistry, their occlusion will not only change before you prep the tooth and after you have finished the restoration and checked the occlusion, but going forward after weeks, days, or even just few hours and years, they will change because their position on the day that you started working was at a adapted centric posture. It was not a 100% healthy centric relation joint. And remember what I said, it the majority of our patients don't have healthy joint. It's not, let me put it this, they don't have perfect joint. It may be healthy enough that we can work with it reasonably stable. Just like me, I'm not perfectly healthy as I'd like to have. I'd like to be. I have a little bit of hypertension. I have a little bit of thing that benefits from, making sure that I don't retain too much water in my system. I am probably slightly pre-diabetic. Certainly my joints are not as healthy as I used to be. I'm certainly not as strong as I used to be, right? So nobody is perfect in so many aspects of our body. And same thing with occlusion. So, so how do you know if somebody has perfect TMJ and somebody has wildly adapted centric posture? From all clinical purposes, we don't know that. When we run into our patients day in, day out. So one of the things that I always keep in mind in my head is that I tell myself, especially if I recognize that their condyles don't look right on the panoramic, I tell myself, okay, this patient's occlusion is going to play hide and seek with me. I'm going to have to constantly, it doesn't mean it's a house built on sand, no, but I am going to have to educate the patient and I am going to have to tell myself that occlusion is going to be fluid. And this is where that concept that I told you earlier about centric relation is a pinpoint, it's not going to vary. Well, how do you say that if I don't know how stable my centric relation is for my patient? Because I don't really know if John Doe had adapted centric posture or how much of a adapted centric posture it was. You know, patient comes in with hypertension, that hypertension, that degree of hypertension, the degree of high blood pressure doesn't stay constant in their lifetime. You know, if somebody was in their 20s and they had no high blood pressure, we don't say that when they turn 60, well, you know, you never had high blood pressure, so I don't expect you to have high blood pressure. No, you can't say that. Okay, and this is where that old timers they keep thinking of occlusion as a only mechanical entity. They think of occlusion as something that they studied off of dry skulls, off of articulator, off of kinematic hinge axis, off of face bows. But what we have to remember is physiology is constantly changing. It does not mean that we're going to get lost forever. No, of course not. But you need to allow yourself that room to be able to tumble with the patient's occlusion. Okay? Don't say that I am so holy mighty when I adjusted my occlusion last week that it was perfect, therefore it should be perfect today. Okay? If that were the case, people should not get any wear and tear in their mouth. Okay? And one thing that I would say, um, so here is the thing. So on page 73, the upper left hand column, the first sentence, beginning of the first sentence, long centric stability of the TMJs, and thus the stability of any occlusal relationship is dependent on the condition of the intracapsular structures. Okay, so what he's saying is that occlusion depends on the TMJ. The stability of the TMJ is what's going to guarantee the stability of your occlusion. So if you have no idea about TMJ, there is no way you can say this occlusion is going to be stable. And that is why, in my humble opinion, a panoramic image of the TMJ is a requirement, standard of care, in my book, for every patient. But the reality is, significant majority of general dentists don't appreciate that. They don't know that. They think taking bite wings and occasional PA is good enough, or even full mouth X-ray. You cannot tell somebody's occlusion with just full mouth X-ray. I mean, it gives me some idea, but no, you need panoramic X-ray. You need some imaging of the joint. If you don't want to do panoramic and you have the luxury of doing CT scan for every patient, other than radiograph, I mean the radiation exposure and the cost factor, I don't care. What is important is that you have the ability to have formed some opinion about the integrity of the joint. When you're thinking about occlusion, you have to think about the joint. Okay? And then he goes on to say, many patients, okay, the next paragraph, the last paragraph there. Many patients in adaptive centric posture also display excessive attritional wear, so they are often candidates for extensive restorative dentistry. Okay, that is true, right? If in doubt about the stability of the TMJs, if in doubt about the stability of the occlusion, it is wise to evaluate using a full occlusal splint long enough to ascertain that the TMJs are manageably stable. And that's absolutely true. Okay. The occlusal splint should be meticulously adjusted with posterior disclusion via anterior guidance. If the occlusion stays acceptably stable for up to 3 months and there are no other concerns, proceed with the restorative phase. Now, there are a lot of details here that he kind of like just gleamed over. I'm gonna editorialize here a little bit. Number one, okay, that yes, splints are absolutely critical in some patients, especially if you think they have significant occlusal instability. Okay, and I'll have chance to talk about that a little bit more later. So I'm gonna kind of postpone that thinking right now for that. But what I will just say is this: the splint should be meticulously adjusted with posterior disclusion via anterior guidance. I wish he had put in one more aspect to that sentence. That is, meticulously adjusted with bilateral posterior support. Equal bilateral posterior support. Before you can have posterior disclusion, you got to have posterior occlusion, right? They are so almost obsessed with anterior guidance because he wants to emphasize posterior disclusion via anterior guidance. That's what he's trying to emphasize here, right? But before you go into disclusion, it has to be in occlusion. What is the requirement for occlusion? They don't talk about that. To me, that's even more important, right? So what is the requirement for occlusion? Bilateral posterior support. Bilateral equal posterior support. Now, if you want to have the anterior teeth contact at the same time, we can talk about the details of this a little bit later today. I don't have any problem with that, but you just need to make sure they are indeed equally loading when they are loading the joint. Meaning, from a clinical perspective, when the patient is clenching. Because, hey, you know, patient has to be able to load the joint without me doing bimanual manipulation, right? Bimanual manipulation, I already told you, I sort of like don't really do that. But in but the concept of it, I fully support that idea where both joints need to be loaded or need to be loadable while the teeth are contacting. Well, how does the patient do that on their own? When they're clenching. Okay. So when they come into initial contact point and then clenching, both instances, they have to have equal contact everywhere. That is so critically important. That is more important than this concept of disclusion. Because that's the starting point. If you don't have equal loading between right occlusion and left occlusion, then your joints are going to be unevenly loaded. If they're unevenly loaded, there you go. There is your, disqualification for healthy joint and centric relation or centric posture. Now, a lot of people don't have that with their own teeth. Okay? The question is, the question is not so much that like, is your blood pressure 120 over 70? It's always the question about what do you do with somebody who's got 132, 135 over 90? Do you put them on high blood pressure medication? When I was younger, they said diastolic of 90 was acceptable. But now they're saying diastolic of 90, people should go on medication. So that's open for interpretation. Okay. And that's the same idea here. When a patient has slightly uneven occlusion in the posterior, how do we decide whether we need to truly treat that first or do we move on with rest of the restorative work at the same time? But needless to say, What is critical here is that you do not ignore the fact that they have uneven bite. Just because just because you don't tell your child all the things they need to correct for themselves don't mean that your child has perfect behavior all the time. We accept our children. In fact, I accept myself with all the faults. I just hope that my faults are not too big, right? That it's going to mess me up. Same thing with my patient. I accept my patient with some faults in their occlusion. Is this something I can work with? Or is this something that I need to bring it to the forefront and talk about it and see if we can change it? Do they need to be in therapy sessions for next 2 years? Okay. So, um, it's you know this adapted centric and the idea about evolving TMJ joint position and how it relates to the occlusion is something that you have to always keep in mind, back of your mind. You don't have to have a definitive idea about what you want to do for every patient, at least as a starting point. But to be aware that this is important concept of recognizing that it's a spectrum. It's not black and white. It's not healthy joint, unhealthy joint. No, it's a range. Okay, it's never black and white. It's different shades of gray. When does it become dark enough? We're gonna say black. When does it become white enough? We say white, but it's still a gray. Okay. Now, the determining of centric relation, chapter 9, you know, uh, you know, um, is not so much of a, bimanual manipulation. As I told you, I frankly don't practice this because to me, I am not here to, I have no desire to say it is a wrong approach, meaning that it's inaccurate or this or that. I'm sure it's accurate enough. Okay. And at least according to the research, it seems to be. Once I learn about the principle and the somewhat of a practice of bimanual manipulation, I came to the conclusion that I cannot do this in my clinical dentistry. Why is that? Because I want to find the picture, and this is why I have, I have this textbook because I don't have these slides for all these things. Let's go momentarily to page 91. That's the cover page for chapter 11. And this is about recording centric relation. You see the picture there. You see the picture of 4 hands in one mouth. And that is so that they can take bite registration. Okay. I mean, can you imagine yourself doing that every time you're taking a bite registration for a patient between you and your assistant? How intertwined, intertangled you have to be in order to have your hands like that with a patient? And forget about taking a bite registration. What about when you have done your fillings, when you are delivering your crowns, and you're trying to check their bite? If I'm gonna say anything other than bimanual manipulation is unacceptable, every time I'm gonna put a articulating paper or a film, my assistant I have to become this intimate. I know that's a stupid way to say it, but I mean, I can tell you my assistant doesn't want to be that close to me. Okay, every time you know, and how long will it take for me to do this on whenever, like when I do my filling or my crown, how many times do I put my articulating paper in the patient's mouth to try to get it right? 10, 20, 30, 40, 50 times sometimes. And every time I'm going to do that, I'm going to assume that relationship with my assistant. Just not practical, in my opinion. Okay? It's no different than me saying I cannot equilibrate every patient that walks through the door. Okay. Dr. Mylene, I was wondering when you're going to stop me. Okay. Sorry. Go ahead.
Thank you. Thank you. Yeah. Just curious. I don't know if you're getting close to the point about the Lucia jig and the leaf
Hmm.
gauge,
Yes.
but I do have a specific question about the leaf gauge.
Hmm.
So with the leaf gauge, doesn't that inhibit complete seating of the condyle?
Well, actually,
Isn't
there.
it like a physical barrier for it in the most superior anterior position? The leaf gauge is a physical barrier.
So I think I understand where you're coming from. Believe it or not, the advocates of use of leaf gauge and any of the anterior jig in page 81 and 82, okay, okay, they think that it actually helps you, facilitates for you to fully sit the condyle. To me, I think that way of thinking is misguided. I agree with you. The leaf gauge actually gets in the way, and if anything, oftentimes the leaf gauge distalizes or forces your jaw to go posterior rather than superior anterior position. Forget about even superior anterior. It even makes it difficult for the condyle to be even in the superior position. So I agree with you. It is a problem. I don't That's why I don't like to use anterior jig of any kind, including Lucius jig, for me personally. Now, I know that my approach does not actually have, shall we say, it's not a perfect solution either. Okay, but in a short answer to you, I do agree that it presents a problem, and that's what I was going to try to get to. When once we agree that bilateral manipulation is just 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 full of potential problems, let's move on to let's move on to other methods in page 81. Okay, okay, page 81. When they talk about anterior bite stops and then fabricating NTI, anterior jig, Lucius jig, you name it, whatever the name it is, the basic idea is the same. Okay. The problem with that is, so the notion is this. The notion is the way of thinking is that uneven occlusion, once your uneven occlusion comes to contact anywhere, before you or your patient can feel it, your brain will detect it subconsciously and deviate your jaw closure. So the idea is you want to take the bite registration without teeth contacting. Okay. So to me, if that's and that's a principle that most people agree with, because the slight deviation is problematic. Okay, in terms of us accurately visualizing where the initial contact point is, that does not coincide with centric relation, evenness. Okay, but then the notion here is that yeah, it's more manageable, but the way I look at it is if your anterior teeth are contacting also, then then uh, then maybe if you're not good at it, that will also invite mandibular deviation anyway. Okay. The way that I do it, if you could imagine this way. Imagine any of the picture on page 81. Imagine. So the way that I do it, some of you have seen me in the clinic before, is this. I do go to patients, let's see, about 10 o'clock, 11 o'clock position, because I'm a righty. Okay. And what I will tell them is, first of all, I don't tell my patient to bite down. I never use the word bite, because if I tell them to bite down, what ends up happening is their habitual bite comes out. The mandible will deviate to the right or left to the front. So I don't tell them to bite down. I tell them to first relax your jaw. Now, about half the patients will, maybe more than that, will innately understand what I mean, and they will not try to bite anything. They will just relax, meaning oftentimes, if I have them in a supine position, their jaw will drop down. Why? Because when the jaw is held in a certain tension in an effort to try to bite things off, it is indeed in a position where they are used to having the teeth come in contact in maximal inner-cuspation. And if the bite is off, then I don't want that, right? I want to be able to capture the bite without having the teeth contact points, telling the jaw to go wherever it wants to go. So So what I do is I ask them to relax the jaw. If they are able to relax the jaw, I'll notice their jaw drop down. So here is the thing. When somebody opens initially, and you saw this, I want to say, let me see. Okay, hold on one sec, because I think it will be helpful if we visualize this together. Where did I see this? Okay. I do want to show you this. Hold on one sec. The pattern of opening is what I'm trying to show you. I saw it, I know. Maybe it's more in the front. Hold on one sec, bear with me, okay? Hmm. Okay, if you know what I'm talking about, if you see what I'm about to describe to you, share with me, okay? What I'm trying to share with you is this. When the humans open their jaw, initially, assuming that they're at a reasonably close to centric relation, we open purely rotation. Once they open the mouth beyond the rotation, if they want to open more than Dawson says 20 millimeters, they have to slide the jaw forward. So, right? If you allow your jaw to just relax and just drop down, they rotate. But if you want, if like, so if a doctor asks the patient, go ahead and open your mouth, even if they don't open 100%, if they open about 50% of their mouth, they're going to translate the jaw forward in order to open more. So at that position, there's tension because they had to protrude the jaw forward in order to open more. So if they relax the jaw, what ends up happening is the jaw that forward drops back to its rotational position. They close about halfway and they drop back. Okay? So that's what you want to communicate to the patient. So I will tell them, go ahead and relax your jaw. When they relax the jaw, then the joint is close to the CR position. At that situation, now what I do is once I notice that, okay, what I will do is imagine my finger instead of those Lucius jig or leaf gauge in the patient's mouth. So I will use I'm a right-handed. So I use my right hand to hold their chin, not to push it back, not to push it back, but I want to feel it when the jaw drops back. So when they have opened and I hold their jaw, chin. When they relax, they drop back. I feel that dropping back. Once I feel that, then I put my index finger, left index finger, between upper and lower incisors. So they're going to act like Lucia's jig. Okay? And then I hold their chin with my right hand, not to shove it back, but I want to make sure it's not coming forward because you cannot visualize it. But I'll feel it if they come forward. And what I want to do is I guide them, and once the lower incisor touches my index finger, I'm gonna slowly withdraw it, take it out as I allow the jaw to close, making sure it's not coming forward. So essentially, that's how I take my bite registration. Now, if I were taking the bite registration for a diagnostic cast, I bring that in all the way until theoretically right before the posterior teeth contact. Okay. But if I don't use Facebook, as Dawson said, that's kind of a mute exercise. But when I do splint therapy bite registration, I will close until they're about two about 3 millimeter. What I imagine about 3 millimeter posterior disclusion open. Why do I want about 3 millimeter? It gives me about a millimeter, hopefully no more than that, for me to adjust to make it perfect. Okay, and then still have 2 millimeters of stability. I mean the material stability. Okay, so it doesn't become too thin. Okay, this is something you have to practice, anytime and every time. Okay, and once the patient becomes predictable in knowing what to do, only then I tell them to just do it on their own. Okay. So let's say, to, to be practical about your daily practice, let's say if I am doing a filling or a crown on number 14. Okay. So what I'm going to do is I'm going to, when I take my bite registration for, let's say, crown prep, okay, I'm going to put my, I'm going to have the patient open the mouth big. I'm going to put my material in place, PVS in place, and then I'm going to hold their jaw, make sure they close down, rotate it all the way in. Okay. I do not have them clench when I take my bite registration for my restoration. And the reason for that is because when they clench, they tend to deviate more, right? Especially if their bite is not good. Okay. And I do want to make sure my restoration fits them well in centric relation first. And from there, I will accommodate deviation and excursives. And the reason for that is because if I only care about their clinching and the deviation, oftentimes in centric, you don't have a centric stop. And that's how you keep losing their posterior support. Their teeth, essentially occlusal dimension, keeps getting shorter and shorter. Now, it's usually not a problem for the sake of vertical dimension, but it does become a problem in the long run because your front teeth will start to hitting too much. Okay? And that's something that you notice that Dawson really doesn't talk about the importance of posterior support. I think he does talk about it later on when we talk about reconstructing and the posterior teeth. Okay? But that's way down the road. Okay? So centric first, and then one more thing, at least with the AccuFilm that I use, um, yeah, if your practice is using paper, I will try to convince them. Acufilm, it does not really cost that much, right? You know, so I think that's a reasonable request for most practices. Acufilm by no means is perfect. It has a lot of faults in it. Okay. However, however, it is probably the most practical bite registration showing articulating paper. It shows you a decent amount of false marking still, so you do have to take a look inside the mouth without the acufilm when the teeth are together. Visualize it so that there is no false. Like sometimes you'll see, oh, that's funny. I see this clear mark on number 15 mesiobuccal cusp. But then you look, you go like that's clear. It's nowhere near touching the lower teeth. Why is it marking? Well, that's what we call false marking. Why? Because the acufilm is still a little too stiff compared to what I would like. And it rubs against the teeth where the cusps come down. Okay. But if you dry your teeth reasonably, you don't have to use Vaseline with acufilm these days to be able to get a decent marking. Okay. I don't like it when patients go like that because to me, that's actually either I can't control how they are, how hard they are biting, or how they are getting into in a different posture. I rather just have them come down initially, okay, and then once I'm reasonably comfortable, there is no deviation, meaning there is no mandibular deviation when they touch. Then I have them squeeze. So load testing. I want to make sure I squeeze that they squeeze once I get them into centric. Okay. Once I'm happy with the centric and squeezing, as in clenching. So centric can be satisfying, but then when they squeeze, you come to the conclusion, yeah, that tooth is still a little too high. So then I adjust that. Once I'm reasonably happy with that, then I will have them go through excursives. If they're giving me excursive grinding of their teeth from the beginning, I have to tell them, no, we're going to do that later. If I satisfy that from the beginning, there's a lot of false marking I'm going to remove, and it's not going to be a good occlusal stop. Okay? So, sometimes I'll just let the patient do this tapping if I feel like, I'm not going to challenge the patient, their personality or their occlusal scheme or whatever. But if I had it my way, if I'm doing more than one crown or one filling, that's certainly how I'm going to do it. Where I guide them into CR, make sure they are in CR, and then I check their initial contact point, and I check their clenching, and then do excursives. I don't bother changing the color. Why? Because it's either dot or a line. Okay, basically. you know, and so it doesn't really matter to me that much. Acufilm that are pre-cut, I use the Acufilm that are pre-cut, and they give you a length about this much. What I'm gonna now do is I fold it in half. Earlier in my career, I was cutting it in half, and to be honest with you, when I cut it in half, in theory, it's more accurate because it's thinner. But in practice, it's not as good because it doesn't give me marking on both sides that I can reliably look at. And also, the supposedly patients studies have shown patients' sensitivity to occlusal discrepancy can be as little as 8 microns, the shim stock. Patients can tell if there's a shim stock stuck between the two teeth, upper and lower. Okay. But the problem with that is the shim stock doesn't give you marking, so you don't know where to adjust. So Acufilm, one thickness is about if I don't fold it, Acufilm 2 at least, which is what I like, red black marking. Okay, uh, it will be um, about 25 microns plus minus. So you can say, well, that's beyond the human perception, Dr. Lee. Aren't you worried that you're not going to be that accurate? And I have to tell you, I understand, but a healthy PDL has a movement of anywhere from, depending on the studies, 50 to 100 microns. So your teeth built-in shock absorber is still more than my Acufilm, okay, in terms of the leeway. Okay, so I feel reasonably justified that I will use Acufilm. Now, the important thing here is this, and it's almost a catch-22 situation. If somebody's bite is way off, oftentimes they have no idea how to complain about it. But once they'll tell you it's high, but they don't really know the significance of it. Once you start adjusting and when you start to get close to it, and as the patient becomes informed about it or educated about it, now their ability to tell sometimes is more accurate than what your Acufilm will show you. But because I am worried about potential false marking of Acufilm and patients' ability to be able to tell as they get deprogrammed, okay, what I will often do is I will listen to what the patients are telling me as much as I will evaluate my own marking. So it's not a situation where I completely ignore what they say and only rely on what I see. It's not a situation where I only rely on what they say. It's you have to process both of them at the same time. And as you get more experience, you'll start to understand when to give the patient. You'll start to be able to give the patient, when to give the patient, okay? Um, the benefit of doubt, you know, okay? So, so, um, you know, well, I'm sure we'll have a chance to talk about that a little bit more. Okay. Um, so, and what I oftentimes will do is once I take the bite registration, okay, and once it's firmed up, I will open the patient, and usually the PVS will stay in the mouth, and then I will have them close again into hopefully same position. So if they go into the exact same spot, okay, then I can say my CR is repeatable. And then I will have them clench once I confirm that they are in the same spot. Why do I have them squeeze, clench? So that I can load their joint. So throughout the whole process, I need to ask the patient, does it hurt your muscle or the joint? And almost always, the way that I just described to you, they'll say, no, it does not bother me. Okay. So, so, um, you know, uh, Dawson, now that I'm getting back to the book again, I'm reading it a little bit. I just had a chance to uh, glimpse on it. Page 82, 83. So he talks about the disadvantages of anterior bite stops. The value of the page 82 on the right-hand column, um, on the subtitle, disadvantages of anterior bite stops. The value of anterior bite stop is primarily in their usefulness as muscle deprogrammers. They do this by separating the posterior teeth so deflective posterior interferences cannot influence the musculature to displace the condyles. Thus, they are an excellent aid in finding and verifying an accurate centric relation. Many dentists prefer to use the anterior bite stop as a routine stop in locating centric relation. This is acceptable. How, but, but, use of anterior bite stop does not eliminate the value or need for learning proper bilateral manipulation. Okay, it goes on to say during equilibration procedures, you cannot mark occlusal interference with an anterior bite stop in place. Bilateral manipulation ensures correct condylar position during closure all the way to teeth contact. Okay, I'm gonna say that doesn't apply to me because I don't use bimanual manipulation. Uh, Now let's go on to the next point he makes. Even with an anterior bite stop in place, load testing to verify centric relation is the only sure way to ensure accuracy. Okay, now the next one. Load testing can be done in increments, starting with gentle loading, first to rule out in intracapsular disorders before firm loading by elevator muscles when an anterior bite stop is in place. Don't worry about that either. It's still talking about loading, right? Bilateral manipulation with load testing has been proven to be accurate without the need for added appliances or extra steps. It's just really, really inconvenient, complicated. Okay. Now, I think what I really wanted to say was figure dash 912, a figure dash 912 right above that. Warning: an improperly made anterior stop, A, can displace the condyles distally. Remember, that's just exactly what I said. Likewise, a leaf gauge can force the condyles distally if used with strong elevator muscle contractions in combination with steep, deep overbite. So any of the anterior stops have this potential. Well, in fact, any occlusal scheme where front teeth are touching too much has this potential. And this is exactly the reason why I tell you repeatedly over and over, make sure your front teeth don't touch too much. Because if they're touching too much, what Dawson's saying in figure 9-12 can occur. And in fact, that is one of the most overlooked occlusal pathologies that I see in my patients. Because another way to describe this is lack of posterior support. Even if you have teeth in the back, if your front teeth are touching too much first, your mandible is getting posteriorly displaced. Okay? So I hope I was able to emphasize to you some of the issues with this determining centric relation, the problems with bimanual manipulation, all that. So if I were to go back to the definition of centric relation, okay, if you were to look up the definition of centric relation according to American College of Prosthodontists, okay, what they're gonna say is, they talk about condylar position and the thinnest avascular portion of the disc being in the superior anterior position. What they will say is this, and this is the thing that I wish people would talk about, and that is they will say, if you Google it, you'll see it, okay? They will say it is clinically discernible with purely rotary movement of the mandible. Your mandible, if your patient relaxes their jaw and I hold their chin here, and you notice that the jaw is going up and down without any hesitation, that there is no back and forth movement. It's just purely going up and down. That is indeed CR position where the condyle is rotating around. And that is why I'm holding my patient's chin with my hand so that I can verify, validate the purely rotary movement. Okay? If you cannot validate that, in my humble opinion, even the bimanual manipulation does not work because you don't really know if it's really at a true hinge point. And perhaps that's where, the prosthodontic group and Dawson have slightly different interpretation on this. I want you to have the confidence that when you start dancing with their mandible, with their left hand or right hand, the way, and once you start able to feel their rotary movement, the hinge movement, up and down, up and down, okay, you can be assured that is within the range. Remember, I told you within the 1 to 1.5 millimeter range of CR. Okay, but while they are going up and down, if you notice they sometimes come forward a little bit and back a little bit, that means you have to assume they are not in CR. Okay. Now, some of you in dental school were taught if you cannot have the patient relax their jaw, right? There are some people, you hold their chin, if you grab their chin like this, they just become a bulldog. They just put force on their jaw. They go, oh, right? You can bet almost all of them have occlusal problem and some degree of TMJ issue. Why? Because they are so accustomed to that programmed position. They're so accustomed to that habitual bite because they are trying to avoid their CR. Why? Because the occlusion is not even. And that's one of the reasons why I hold their chin when I am taking their bite registration. Okay? Because I can tell when they are about to, okay, when they are protruding or going left or right, things like that. Okay? So, I'd like you to, practice. One of the things that, one aspect of it is I hold their chin. I'm a righty with my right hand, and then I put my left index finger, as an anterior jig. And as I have them relax the jaw and as they rotate upwards, when they close, now when they close, some patients, as a reflex, because my finger is in the front, they want to bite that finger and they will protrude their jaw again. And I tell them, no, don't try to bite me off. Relax. What we're trying to do is to close in the back. Okay. And more difficulty you have communicating with them, at least on my part, I can tell you, more off their occlusion is. Okay? More bulldog they are, more occlusal problem they have. You can almost bet bet on it. Okay? So so let's take a little break time here. Okay? It's 10:45, 10:46. Okay? We're now going to get on to the load testing part, which I'm not going to spend too much time because I think we already talked about that. But I do want to spend more time about recording. I know that I was ahead of it because there are some concepts there that's important. Okay? And hopefully, I think we'll have a chance to talk about vertical dimension because that's obviously a very critical part. Okay, let's take a break time until 11 o'clock. We regroup at 11 o'clock. My thinking is we're going to go until about 12:30ish today. Okay. Um, If you have any questions, clinical questions, feel free to send me text or email. I'll see you back at 11 o'clock. Thank you. So one of the things that I wanted to remind you again is this. In page 89, Dawson's sharing with us the figure 10-8, degenerative bone disease can produce discomfort when load testing compresses the disordered tissue. So we haven't actually directly talked about Dawson talking about this, but we a little bit. Always remember the we established that the joint affects the bite. But remember, bite affects the joint as well. It's a two-way street. Bone is a live tissue that responds to the joint. I mean, that responds to the load. Condylar bone will respond to the load. So when they are doing this load test, it is important that that they have the ability to do the load test, just like Dawson is saying, and have no pain and have stability. In my book, as I keep emphasizing, I do that by having the patient clench the jaw. When they clench, I want to make sure I'm holding their chin. When they clench, I want to make sure the jaw does not deviate too much left or right. Why? Because if it's deviating too much like that, that means there is an occlusion that is off. And eventually it may lead to, okay, it may lead to uh, unstable the joint. So you want to have minimum CRCO slide, especially if it's somebody I gave them splint or if I did major work. Um, with implants also, it's best if they don't have any slides. If I'm doing simple filling, single crown here and there, and if they slide and they have no other symptom, I probably wouldn't worry about it. Not because it's okay, but because it's not something that I'm at least contributing to their problems. Okay, so you know that degenerative bone tissue is something that, as Dawson points out, happens often enough, and you want to make sure that you are mindful of that. And so, um, it's let's just say that you know their ability to clinch. What we don't want is patients who cannot clinch. It's okay for them to clinch. It's just that when they're clinching, we want to make sure they're not breaking anything and they're not getting continuing the degenerative change process. Let's go to the centric relation, recording of the centric relation. Okay. Um, the reality is that the best centric relation recording device material is something that is really, really soft when you're taking the bite. And then once it's firm, once it's set, it becomes really, really, really hard and it does not deform. Meaning that when you're putting it together, it does not cause it to deform so that it gives you then, by definition, a wrong bite registration. PVS satisfies one aspect, our usual PVS bite registration, and that is that it's really soft when they bite down. Okay? But the problem with PVS oftentimes is that it's too accurate. What I mean by that is if I were to take bite registration with PVS, and if I took the cast with alginate, and especially if the alginate has bubble in it, then that discrepancy in the detail will cause my bite registration not to be accurate. So if you're truly concerned about having diagnostic cast and mounting it together, or at least take a look at it in your hand together, what you need to do is to make sure that you get rid of all the positive bubbles in your cast. Because whether it's PVS or alginate, almost all full arch casts will have some bubble here. And if the bubble is something that's going to come into occlusal contact or contact with your bite registration material, then you need to get rid of the bubble. And you would think the lab will do that, but no, lab guys don't do that. Very rare a lab guy will do that when you send them the cast. So I will do that. Now, here's one thing that's going to complicate it a little bit. If you are going to pop off the bubbles on your cast when you send it for the night guard splint, you have to be careful not to pop off too much, especially on the occlusal surface area, because if you pop off too much and now you're making indentation into the teeth, instead of a positive bubble, now you're creating a notch or excuse me, or you're creating a negative imprint into the model. And if they make a acrylic to fit to that, now you have an acrylic splint that's gonna wobble. Okay, so you have to keep in mind, okay, with for the night guard thing, when you're popping off the bubbles, where do you pop it off? How much you scrape against the stone? Kind of think about that. Okay, I think I showed you that example where the lab, I wish they would use a little bit of wax to block out all the occlusal details so that those things don't become a problem. But you know, they're just not predictable guys. They don't do things always the same way. So sometimes I know that that's an issue that I have to do the grinding on my splint to get rid of the too much grinding on the occlusal surface. So keep that in mind. So PVS is a problem in the sense that it's too accommodating if there is a positive bubble on your cast. Okay. Most waxes are also accommodating that. When they talked about the ideal material where they will snap off if it's cold and if it gets distorted, in theory, that's a good idea. But again, in practical world, that's kind of pain in the butt too. Okay. Um, the best articulating registration material is actually, at least in prosthodontics, what we do is there is a company called Panadent. They sell Panadent articulators, and they sell a very thin metal wafer. It's a very thin sheet that's metal. They can flex a little bit, but not too much. That looks like this wax that you see in figure 11-2, 11-3. And what we now do is then we apply um, uh, PVS, bite registration material, onto the one surface, one side, and then we apply that onto the maxilla first. You get the maxilla registered. And once you have that and it's staying in the place, then we take it out and we put the PVS onto the mandible, put it into the mouth, and then we slowly guide them into CR. The problem with that, unlike wax, is because the metal is straight and they will not deform, that you end up having a bite registration that's relatively open. So if you don't have a true Facebook or axis rotation, axis of rotation, like a pentadent, I'm sorry, pantograph, then it's there's a margin for error. Ultimately, what I want to emphasize here is this. I told you that CR is a range. Little bit of the material shortcomings that introduces error into our methodology, as long as that stays within the closeness to the range, you just remember this is something I have to work out with the patient's teeth. That way, I don't get hung up on these details. If you get hung up on too much on these details, then the dentistry becomes way too convoluted, way too complicated. It's gonna drive you crazy. And that's where that range of CR becomes a very useful knowledge for me. It allows me the room to dance with. It allows me a little bit of less than perfect accurate bite registration. But as long as I satisfy the rotational requirement of my CR, and I can confirm by holding their chin that they are not going all over the place, then I can be assured that I'm close to the CR. Okay? And I think when you remember that, it's going to be close enough. Okay? When you have all these pictures of, figure 11-2, 11-3, 11-4, one of the things that they, um, I don't think they showed here well is this. When you put it in 11-4 in the mouth, assuming you're the only one who is doing it, if you are using wax, what you want to do is soft enough. You compress it against the maxilla first, so it becomes stable in maxilla. You cannot just hold it in place and have the patient close and then expect it to stay in place while you are doing manual manipulation. And that's why you need four hands like that. Okay. If you're doing alone, you register into the maxilla first. So now when I'm doing it with my PVS, I have to admit I should dry the maxillary teeth first because a PVS, if the maxillary teeth are too wet, they bounce off. You know how they just slide off. So you don't want it to be too wet. A little bit of air dry is fine. Okay. And then when I put the PVS material in against the maxillary teeth, if you imagine, what I want to do is, even though it's not possible, I want to go as perpendicular as possible to the occlusal table with my PVS, the mixing tip. So even if I'm going in my second molar, I don't, if my teeth are like this, I don't want to shoot my PVS like this because then they tend to slide off, especially if they're not really dry, the teeth. What I want to do is to shoot my PVS with my mixing tip as directly against the occlusal table as possible. Okay? That way they become stable. They stay stuck to the tooth structure in maxilla. Okay? And I use fast set because regular set takes too long. I don't have that kind of time. Number one. Number two, if they take too long, it actually invites patient to move their jaw. And once they get into CR. Okay? So I use fast set only. These days with the economy it is, people are always looking for lowest costing. I don't think, to be honest with you, PVS for bite registration needs to be the most expensive stuff that's out there. Okay. Um, uh, Cheap stuff, yeah, it's gonna be accurate enough. If as long as it's PVS, it's gonna be accurate enough. You can get the cheapest one you want. Okay. But do get facet. You know, the one that I use in my office is from Discus Dental, and is it or Denmat or one or the other? I forget. If they bought the product line from one or the other, and then it's called Vanilla Mousse, a fast set. Okay, that's what I use. It's really hard once it's set. Okay, and then one once they are stable on the top, then I will go ahead and guide them into the CR. The idea that they are showing you the picture with 95, page 95, where you have an anterior jig and have the patient in CR already in occluded position, and then you squeeze in the material, it just creates too much chaos. Okay, so what I would do is that I would oftentimes I just do right and left. I don't connect it in the middle. Why? Because especially early on in my career, I wanted to see my hand and the thickness and all that. Okay. Um, but if I want to have one piece because that is easy to remount and everything, when it comes to anterior portion, what I will do is I don't put it on the incisal edge. As I come from lateral to lateral, I'll kind of go into the lingual aspect of the occlusion. I don't put it right at the incisal edge. Okay. On the posteriors, I put it on the occlusal table. When it comes to the front, I will put it not on the incisal edge, but on the lingual aspect. So when my finger goes in there, it doesn't touch the bite registration too much and it doesn't kind of distort that area too much. Okay, Dr. Mylene, yes.
Um, Again, I just wanted to say, doesn't the material become a physical barrier to complete seating of the condyle in the most superior anterior position? And in this demonstration, in this chapter, the recording of the CR, for what purpose? Like making a crown?
So
What
he's
is the point?
primarily talking about when you're doing full arch like this, you are either doing a full arch rehab or diagnostic cast mounting. He is primarily showing you examples of diagnostic mounting, right? You know, so when we are doing quadrant dentistry, we obviously wouldn't use this kind of thing, and that's where I find frustrating because a lot of these big names they don't talk about everyday dentistry. They just talk about full mouth stuff all the time. And it's up to individual practitioners to somehow translate that into your quadrant dentistry and or even single tooth dentistry. So I appreciate that. Um, you know, if you think about what Dawson's saying about bimanual manipulation, loading of the condyle, he does that bimanually without having the teeth come in contact. That's the whole idea about going behind the jaw, and they want you to relax the jaw and then load the back first and then close. In real life, I just don't find that to be, maybe I'm just stupid. I just never learned it properly. I just don't find that to be that practical and easy to replicate every time. And this is why I say, once I accept CR has a range, that these variations of technique are within the range of the CR. When they talk about bimanual manipulation being the most accurate, okay, that's within the range of statistical deviation between that and chin point guided. It's within the range of 1 to 1.5 millimeter. And that's why I feel confident as long as I can clinically validate the CR by watching out that part of definition where the condyle, where the mandible is limited to pure rotary hinge movement. That is a critical part of the CR definition you need to remember from a practical perspective. And if you think about it, Dawson did not really express it that way about requirement for CR. Okay, he does not really talk, but here and there he does allude to it, and I wish I can find that. I'm gonna find that little drawing where the it basically is a drawing of path of mandibular opening. But yes, go ahead, doctor.
So once this is accomplished, like you have the bite and reasonable within the range of CR, so that mounting you can use to evaluate occlusal interferences in the lab.
Yes, yes.
How
And the
do
reason why I say that's acceptable is because let's be told, you know, provided that you had proper identification of the axis, the condylar axis, and or you have done the proper um, I'm sorry, Facebook, okay? You are gonna be within the arc of closure where you're gonna close. And that is what and that is why I am saying this idea about my hand loading the condyle is going to be truly maximally loading the condyle comes into question. We all say how strong the masseter muscle is, patient's biting forces are. I don't think I can conceptually accept the fact that my hand can load my patient's disc as strongly as the patient's muscles can. The drawing picture that I was looking for is actually in page 142. Okay, so that we have the figure 15-1. Okay, so what we're trying to show there is this: the red line, the line B. Okay, red line, line B. If you on that the picture A, on the A side on the condyle, there's a dot there in the middle of the condyle. Okay, theoretically, in prosthodontics, we're gonna call that kinematic hinge axis. Okay, and if I were to have a what do you call it? The little compass like drawing, you know. So if one part of my I actually have it. I'm a nerd, so I have it in my desk here. Where is it? I can find. Shoot. Hold on. I know. Here we go. This is so. I don't know if you ever used instrument like this when you were like younger and drawing things in prosthodontics. So if I were to hold this one part, ouch, ouch! I poke myself. If I were to hold my side here, and if this is, you know what? Okay, hold on. I need to get rid of my blur background so everything is in focus. So if I were to have this and if I rotate this, right? So theoretically, on my film, if I were to take a lateral ceph, if I put one dot on my kinematic hinge axis and I rotate this like this line here is what we mean by hinge movement, okay? Because this joint is a hinge. That red line in the front by the incisor is gonna match to this circular movement. And this circle evolves around my kinematic hinge, that red dot in that condyle. And that's what we mean by hinge. It is just purely rotating around there. And we know from studies, if your condyle is not in that hinge position, what ends up happening is the purely circular movement becomes wobbly. And you're going to feel it with your hand. So understanding that part of the muscle move or the jaw movement gives you the freedom to know that what you have is the hinge. And once you're at that hinge, then you are, for all practical purpose, at CR. You don't have to guess. And this is the part that they don't tell you if you're not a prosthodontist. And we come to this conclusion after reading article after article about anatomic and kinematic hinge axis. Okay? So so the mandible, what it does is initially they'll go down the line B, following the line B, and then if they want to open more, then it has to go deviate and then go forward as it continues to open. So if I tell my patient to bite down from their open position, when when they rotate it and then slide open, they'll close in the front position. So when they go down further from B, your condyle is now, if from out of its hinge position, is down. If I tell them to bite down from there, they're almost always going to be biting in front of the CR. And this is why you have to sort of convince the patient's jaw. I say you have to sort of whisper to the jaw, go back to your hinge position. Your hinge position is your home position. Why is it home position? Because we learned from Dawson that's where the muscles are most neutral. The lateral pterygoid especially is not firing. It is most relaxed because your disc is in the proper position. Okay? So that is why understanding this concept of the mandible being in CR equates to hinge movement becomes such an important critical concept. If you think about it, it's so simple. Once you start doing this and you have practice and you start realizing, oh, they actually do this. Okay? Then you go like, why is it such a big deal? It's not. It's a big deal only because people don't approach it this way. They think somehow CR, you have to find it. No, the patients will find it for you. If they cannot relax their jaw and drop their jaw back, then you can automatically assume they have some degree of bite problem because the muscles are hypertonic. And once they have worn the splint, and once they get deprogrammed, then they will do this almost effortlessly, almost all of them. Okay, so you notice that that drawing is at the section of the book envelope of motion, and that's going to become an important topic that we're going to talk about. So to let's go back to page. Um, Let me see the chapter 11 recording. Okay, so So imagine that if you have the page 95, okay? So basically, he's saying you can use either PVS or wax when you are doing this recording if you use an anterior jig. If you look at the recording medium he used for on page 93 and 94, if you look at it, he has no anterior jig there, right? Front teeth are not touching at all. And that's fine. Whether they touch in the front or not, that's not the criteria. The criteria is whether they were in CR. And from a clinical perspective, whether it's clinically discernible is if they have rotary movement. Yes, Christine.
Um, how does this apply in digital dentistry world?
Excellent point. So, if you are doing bite registration for a diagnostic wax up on a full digital full arch, okay? The way that I would do it is I would put PVS bite registration in the mouth and I take the bite first. Whatever opening dimension that you want, okay? And then once it's set, I will put it only one side. So if I put my right side bite registration, then I can go ahead and take my digital bite registration on the left side. And then I take out the right and put my left bite registration. I have the patient close down to it, and then I take bite registration on the right side. I mean the digital bite registration on the right side. Then the AI can put it together. Because digital dentistry basically forces the patient to give you almost always just maximum closing, right? And then that means wherever they slide, they just go in there. Exactly. And that's a classic example. I didn't think about that now that I'm saying it. Classic example of more technology does not necessarily mean it's going to be better dentistry. Okay.
You would
Those,
still
go
have
ahead.
to do the PVS.
Pardon?
So you would still have to basically do this way, the traditional way with the PVS.
If you're doing full arch bite registration. Now, if I'm doing one tooth dentistry, which
Right.
is happens more often, do
Mhm.
I do that? No, I'll be totally honest with you. I don't. Okay. What I do instead is this. Um, Before I start the prep for a single crown, and this is probably applicable to all of us more on a daily basis. Okay. I will evaluate their CRCO slide before I start prep. Okay. And I make my mental calculation. Is this an acceptable bite CRCO slide? Okay. And most of the times, we're going to accept it because it's a single tooth dentistry. As I said earlier, single tooth dentistry, I really don't try to change their bite that much anyway. But the reason why I will start with that is because I want to know if there is truly, especially if you're doing number 15 or number 18, the last tooth in the mouth. Occasionally, especially if the tooth was broken or about to break or has um, mobility and whatnot, if that tooth was the one that was in preventing your CR, if that was the hyperocclusion, and oftentimes they are, I noticed that and I go like, oh, it could be that tooth. Anyway, after I'm done with my prep, I'm done with my prep, what I want to do is I'm checking my clearance, right? When I'm checking my clearance, I guide them into CR and check the clearance. Do I still have the same slide or not? Okay. If I don't have the same slide, hallelujah, great. I make sure I have enough clearance and I take my bite registration fully closed. The way that I do it is I still guide the patient into CR, have them bite all the way down. And so when I'm doing scanning, I do the scanning myself. My assistant is there helping me. I do the scan myself. I have the patient close down all the way by me holding their chin. Once it's at that point, my assistant, I replace my hand with my assistant, okay? And my assistant holds the jaw. And my assistant wants to make sure it's not moving. At that point, I retract the cheek. I put my scanner inside. I take my retractor out, my mirror out, because there's too much stuff in their mouth. Because if it's too much stuff, they open or they move, right? And then I can guess going up and down and slightly from posterior coming forward and take bite registration. Okay. And I have found, at least with my system, that what I want them to do is I tell them I don't want them to clench too hard. So I tell them go ahead and close, close, good. Stay closed and gently biting down. I have, and obviously different people are gonna interpret what it means to gently bite down. But at the same time, I don't want them to clench down either. Okay? So so that much you have to be willing to adjust the occlusion later on a little bit. Okay? But I will do it that way. I will tell them basically once I guide them into CR, I tell them stay in this position but bite down gently. And then and then I will go ahead and scan. Now, I don't know, I know the young doctors, you are more in an office where they have in-office milling. At least my office right now, I have my in-office milling. So, you know, the Glidewell system that I have, their default value for zirconia is minus 400 microns. Assuming that the digital scan is perfect, they want me to make the crown 400 microns too low. To me, that's not good because they're not touching. Now, if I do it like that, almost every one of my patients will say, oh, that's great. It's not high. It's not touching. And I can cement it right away. But I know that that's not really how what is gonna happen is it's gonna lead to anterior contact too much, and I'm gonna lose posterior support, and my adjacent teeth may end up having too much pressure. So what I might have myself have found is most of the way that I just described to you, I end up doing just a little bit of touching. If I do somewhere around 270, 280, no less than 250 microns. Somewhere between 250 and 300 microns is what I try to gauge it to. And then my patients will tell me it feels little high, especially when they're clenching. So it gives me a built-in test for clenching part. And I can do just a little bit of adjustment. Okay. But there is a lot more to it than the just 250 or 300 microns because what is the patient's PDL compression? How much are they really clenching down? Those are all aspects that play into it. If I truly want to just expedite everything, and if you want to do what the companies are telling you, if you do, my guess is this: if I do minus 300 microns on every teeth, almost always I'm gonna be either perfect or slightly low, and my chair side adjustment will be almost none. But deep inside, I'm gonna know they're not touching enough. If they're not touching enough, then what ends up happening eventually is that you have more chance of excursive contacts, right? So, so I don't know if that answered your question, Christine. Yeah. Okay. Thank you. Okay. So, but here's the interesting thing that I wanted to show you here. So, one little trick that I do. Page 96 and 97, Dawson shows you the bite registration of patients who have lack of posterior teeth. Now in dental school, you were taught to use base plate and wax rim. Well, the reality is when you're in private practice, you don't have time for that because most of you don't make it yourself. You're going to send it out to the lab and well, I need to prep right now. I need to take the bite registration right now. And even if you have the ability to make it, well, how much time are you going to take to make a base plate and then put a wax rim on it and all that? It's crazy. So I essentially do what Dawson did here, but without the wax, because with the wax, he uses a paper clip. That's just so flimsy. It's going to fall off. The PVS is not inherently going to stay with the wax. So what I will do, if you take the picture of figure 11-11, what I'm going to do in that situation is, so let's say we have those 3 teeth that are prepped that's going to receive crowns. Okay, let's just say that. And the rest is going to be RPD initially, or they're going to be implants later on. Let's just say that. Okay, so what I'm going to do is I make temporary based on whatever the guessing that you have done, and I'm happy with my temporary height and shape, and I can come to the conclusion because of the thickness of my temporary, I have enough thickness I can anticipate for my final restoration. Okay? You cannot just do depth cut the way dental school taught you with your front teeth reduction and say, I cut back 1.5 millimeter, that's enough. You cannot do that. Because those teeth may have been in hyperocclusion. Why do I mean by that? What if they were always in interference when I did phonetic testing? And if you never checked phonetic testing after you prepped, they may still be in contact. And if they're in contact after prep, then that's gonna be when you make a crown on it, it's gonna touch too much. So the phonetic testing has to be satisfied after you provisionalize. That means after I prepped, if I were to do phonetic testing, there's gonna be plenty of space. And then I make sure my temp my thing my prep my temporary is good. I'm gonna take my initial bite registration with my anterior crown only with the temp. And the way I'm gonna do it, I'm gonna dry the upper. I'm not gonna bother to dry the lower, those 3 teeth, temporary. I'm gonna dry the upper teeth. I'm gonna put my PVS on all of the upper full arch. And then I'm gonna guide the patient into the way that I described to you with my temporary into the upper. Okay. Now you're thinking like, yeah, but I need to give them the prep teeth, not the temporary. I know, I'm gonna get there. Okay. Now what I'm gonna do is now so it registers all of the upper teeth and just the front 3 teeth. Okay. Now what I'm gonna do is I'm gonna make sure I dry the posterior of the upper, the one that's not touching anything against the lower because it's edentulous. You do not need to use any adhesive as long as there's not too much saliva or water contamination onto a set PVS bite registration. I can add as much PVS as I want and they'll stick together. So imagine that wax rim on page figure 11-11 without the paper clip. I open the patient's mouth. I ask the patient to open. I'm gonna apply more PVS material there, add on to the height. So what you don't want is PVS that's too runny. You want PVS that's pretty thick, and that's gonna set relatively fast. So you make them stick out towards the edentulous ridge, and then I'm gonna have them close again into the repeatable CR. Because of anterior 3 teeth indentation, it's gonna go into the same spot. If you're lucky, that PVS will make a registration into your lower ridge, just like figure 11-13. You don't have to put as much as 11-12 of PVS. You just need something that's gonna predictably touch and pick up most of the ridge in the bottom. Okay? one side. Now, if I recognize I only picked up one side, well, don't worry. I dry out the other side and I'm going to add some more again. I can add 3, 4, 5 times if I want to. As long as there is no saliva contamination and water contamination, that's too much between the layers of PVS, they will stay stuck together. Okay? If you want to separate it, they'll become separated. But when you send it to the lab and for the mounting purpose, they'll stay together. Once I am satisfied with the posterior stop, right? Okay. Now what I can do, okay, is I'm gonna remove my temporary crown in the front, right? And just apply little tiny bit to the prepped space of the PVS on the upper and guide the patient into CR. Now the ridge in the back will make sure it's repeatedly going into the same spot. So now I have picked up the prep in the front and the edentulous ridge. And they can mount those casts against the upper. You can do this even if it's only unilaterally missing space. Now, when you think about it, when you are edentulous in the posterior, either unilateral or bilateral, when you are doing your registration, okay, your registration, are you truly able to do load testing with that? Not really. I mean, with your bimanual manipulation, theoretically, yeah, I guess, but at least the way that I'm doing, not really. Okay. And again, it's still acceptable. Why? Because there is going to be that range of CR that I'm going to need to do. I know that I'm going to need to do some adjustment later on. I hope so far what I said about it, it makes sense. But knowing this PVS trick to take your bite registration bilaterally when one or both sides are um, uh, edentulous is a very useful knowledge that you can have when you are doing this bite registration here like this. Okay? Makes sense? So far, I hope it makes sense to you. And at any time when you come to the conclusion that you need, or you need to ask questions, feel free to ask me questions. Okay. Now, the drawing 11-14 shows a very good, shall we say, illustration of why a bad articulator is going to be not something you want to use for opening or closing of your arch. So they're giving you the demonstration of the picture of where, this is a Galletti articulator, which is not anatomic at all, but you look at that articulator's the condyle element. So if you have the dotted line condyle element, and if you want to close the VDO, it's gonna be following that arc of closure from the center of that articulator condyle. And in this drawing, that means there's two arrows. The one that's going vertically straight up is the path of the rotation. But if your condyle is truly anatomic when it's much higher up, then when you close, your teeth, your arc will close sideways a little bit, 45 degrees. And that's what he's trying to demonstrate to you, the importance of using reasonably anatomic articulator in this situation. Now, going back to Chris, your question about digital dentistry, digital articulators do not in any way resemble this condylar relationship. Digital articulator is just purely just going up and down. It does not have a rotation point where they go like this, at least the last time I checked it. Okay, so there will be built-in error whenever you're closing and opening in digital articulator. Okay? Okay. So, when you start mounting your diagnostic cast this way, what you're going to find is that a lot of people's CR have have uh, interferences, and that's why they have that initial CRCO slide. The best demonstration that I can make is figure 12-2. If you look at 12-2, 12-1 and 12-2, what Dawson's trying to point out to you here is that even if the diagnostic cast, the orthodontists show upper and lower just hand articulated, even if it looks really good in a uh, uh, 12-2A, by the time you mount it, oftentimes they will only contact in the molars, second molar, and you will have slightly open bite like this. And the reason for that, and he's giving you a clinical example of 12-5, figure 12-5. If you have the patient bite down, it looks like a upper picture A, but when you take it in CR, it's going to be like a B. And the reason for that is this. Figure 12-3, he's trying to show you when a patient bites down on their full closure, teeth appear to be in full occlusion. And everything looks good. Even the midline may coincide. But in condyle, your left condyle in this situation has moved down a little bit, or medially, laterally moved a little bit. And when you truly take bite registration in CR, right before the interference on the left molars are contacting in figure 12-4. So in 12-4, right before they make the first contact interference, the condyles are centered together, both of them. But as soon as they touch, because it's an interference, only one contact, it's not a uniform, stable contact, mandible will slide. Mandible will slide to get more contacts. And as mandible is sliding, your condyle will slide and oftentimes end up looking like 12-3. Okay? So, again, this takes time for us to appreciate this in the chair side because I'm not spending time with you at the chair side. Okay? But if you just pay attention to these things right now we're talking about in the mouth, if you remember to when you're hopefully not too busy, you're gonna be able to make these observations. Um, I think it makes a it's important that I guess I make the point of going back to page 100. Page 100. So he's trying to demonstrate to you that when we are mounting with the face bow and a bite fork, we're trying to replicate the articulator condyle to the anatomic condyle, okay, in figure 11-17. So if you look at figure 11-18, if you look at it very carefully, okay, he has the bite fork in the mouth, and there's a wax that's indenting into the maxillary teeth. And then if you look at it, okay, there is that element that goes all the way to almost to right in front of the ear. Okay. And so what that does is this, the picture is actually not accurate enough. The part that goes to the ear that comes out to the front, what it does is it actually attaches to my mandible. And when my patient relaxes the jaw, and when I'm able to just go up and down in pure rotary movement, remember I said pure rotary movement, hinge, okay? Okay. If I move that dot point up and down, forward, back, I can find the spot that does not move up and down or back and forth. It stays stationary when my mandible is going up and down. It just rotates like this. And at that dot point is where that 11.9 marking the center point of the indentation, and you make the, he says, aligning the face bow to the condylar axis. So idea is you make that dot become the center of the metal ball in your articulator. When you do this exercise with the patient, you realize, oh, indeed, my patient's jaw is able to do pure rotary movement. And this is something that I did during my training to understand the validity, physiological validity of this. Okay? Now, when you do a ear bow, do they have a picture of a ear bow? I thought they did. Right. So I know that different schools use different things. In page 98, in the Facebook transfer picture, that's an example of Dana articulators. And instead of trying to figure out where that dot is on your joint, what they do is to make it easy, they have the Facebook that goes into the ear, right? And what they have figured out is by trial and error, they have averaged out the relationship of one's ear to that dot point in your joint. Okay? So that ear bow is designed to be slightly longer, knowing that they're going to be into the ear. And that's why when you use that, you have to use the same articulator system that they have worked out that average distance and the relationship. Okay, you have to use their jig, mounting jig, and all that to take advantage of the research that the company has done to get you close to that condylar axis or kinematic hinge axis. Okay, so when you are reading it, if any of that did not make sense, hopefully when I just explained to you, that will make sense. Now, let's talk about classification of occlusion. You know, if you go into this, and this is a extension of centric relation and adapted centric posture, because he's talking about page 107. I'm going to go back to those discussion pages, but page 107, he talks about type 1, type 2, type 3. Okay? Type 1 and then type 1A is talking about basically people that you are able to repeatedly get centric relation, whether it's healthy joint or adapted joint, adapted posture joint, right? And then type 2 is conda must displace from a verifiable centric relation for maximal incuspation to occur. Type 2 basically means anybody who has CRCO slide, the way that you were taught in dental school. Okay? So on that page, I thought what was important is all the very last sentence in page 108. It says, treatment may be reversible with the use of an occlusal splint, or it may be direct using equilibration, orthodontics, or restoration to correct TMJ occlusal disharmony. He uses the word disharmony. I've been using the word discrepancy. So what he's saying is that you need to do occlusal equilibration or orthodontic treatment to make your CRCO slide coincide together. Again, this is really not applicable for single tooth dentistry. And that's why when GPs read this, they get confused because they think this has to apply for everybody. Yeah, it's very, very confusing. You can't do that. You're gonna get in trouble with the dental board because your patients are gonna say, Dr. Lee is a crazy guy. He wants to grind all my teeth. Okay. But where it is important is this. If you recognize that, and if they have some history of TMJ, if meaning they have history of dislocated jaw or TMJ joint pain, muscle pain, if they had worn splint therapy before, what you want to do then is to do splint therapy and deprogram them and truly be able to decide if you indeed need to do occlusal equilibration before you do any major work. If you're going to be doing 3-unit posterior bridge, if you're going to be doing implant crown, you need to at least mentally go through this exercise. Because with an implant crown, if the patient's jaw is constantly sliding back and forth, you run the risk of your screw becoming loose, or you run the risk of losing bone. Because if the screw is not getting loose, you may be overloading the crestal bone. Same thing with the teeth. Same thing with the bridge. Now that there is more at stake and you cannot sort of hide that one tooth. If you're doing single tooth dentistry as a filling or crown, to a certain degree, you can sort of hide that tooth underneath all the other teeth schematic that's working right now for the patient. And that's why we get away with this without touching the overall occlusion if you're doing one tooth at a time. You basically tell the patient, see, you came in this way, you leave this way, same thing. But there comes a point as you're doing more and more teeth, you cannot ignore that. And as a clinician, you have to decide when that point is and then know how to manage it. And how you manage it is not by sending the patient to TMJ specialist because they're going to screw it up. But at some point, you have to decide, how do I make the CR and CO coincide together? Sometimes just giving them night guard splint is good enough. They can function during daytime in CO and at nighttime in CR. And many patients will find that to be acceptable enough. And then I don't touch it anymore. But after I give them the splint, which is reversible, like Dawson says here, we come to the conclusion that discrepancy, disharmony, becomes more noticeable, or patient cannot ignore it. They come in and say, Dr. Lee, I'm happy with your night guard, but when I take it out in the morning, I notice my teeth are uncomfortable at first. Okay, so I need to think about those things a little bit more. Okay, as I am thinking about this variety of maxillomandibular relationship. So to me, the classification itself is not that critical, but the concept of of bone to bone CR relationship. I say bone to bone, not because I'm saying there is no disc in there, but maxilla versus mandibular relationship, and then how the teeth come together If there is a disharmony in that, bigger the disharmony, bigger the problem. And when the disharmony involves lateral shift, that's a bigger problem. I think somewhere in the book, I hope some of you will remember, Dawson says if the disharmony is bilateral, meaning right and left occurring at the same time, and is primarily forward and back, they are more acceptable. It's a unilateral, meaning they're only touching on one side, and the discrepancy is to the mostly to the right, to the left. That becomes bigger problem. And that's true. Clinical dentistry, I can tell you that is true. And the reason is because in yourself right now, you can test it as you're listening to me. If you move your jaw slightly forward, okay, and kind of stay like that, most of us can do that for hours without too much trouble. And in fact, when we get stressed out, we tend to do that. We either tend to clench, and when we're clenching, we slightly clench forward, or without clenching, but we tense our jaw slightly forward. Okay? That is not a problem. That doesn't really make you that fatigued. Before the fatigue comes in, you can do that for a long time. But if you try to move your jaw sideways and keep it in that posture for a long time, that becomes uncomfortable relatively quickly. So our joints have the ability to go sideways, but it is not highly adaptable that way. When we go forward and back, it's relatively adaptable. Okay? But not laterally. It's just overloading a little too much. And one thing is, because it comes to my mind right now, that is important, is when my jaw goes laterally, you have to remember, even though I say like this, in real life function, there is my jaw doesn't go this way only, it rotates a little bit like this in function. So from my CR, superior anterior, my jaw condyle has some room to go posterior. And that has to be accommodated for, not because I'm going to push it back, but because when my patient's jaw goes to the left, if my jaw goes to the left, my left condyle is going to go slightly posterior from CR. If my jaw goes to the right, my right condyle goes slightly posterior from CR. And my left condyle goes forward, it rotates forward. Okay? So from CR, if I want to make sure my condyle is going to be comfortable, I do need to make a little bit of teeth relationship comfortable, even if they go slightly posterior. So the point that I want to make is, if my CR registration happened to be slightly retruded, it's okay. Don't get too hung up on that. The whole point here is the condyles need room to move around. And while it's moving around, I don't want teeth to bump around. That's the whole point that I want to try to say. Okay? Now, one of the best part about this discussion in page 104 and 105, in my opinion, is how Dawson says Engel's classification of occlusion is inadequate. And I hope you were able to follow his logic and understand that. Engel's classification has zero consideration for the condyle. And in my opinion, that is one of the reasons why those smart people called orthodontists are clueless about occlusion. As long as they only get stuck with the idea about Engel's classification, they'll never truly understand CR or the occlusion. Now, The reason why they do that, part of it is their training. The reason is because they're taught, if you think about orthodontic programs' official name in dental schools, they actually include the word orthopedics. It's not because they just want to be fancy. Their idea, at least in theory, is that they want to manipulate the skeleton as well. So what I mean by that is they want to be able to expand the arch. When they're expanding the arch, especially with growing people, they are affecting the bone. If they take somebody who's a class 2 and try to make them into class 1, one of the aspects they're doing is to trying to elongate the condyle to truly make them become skeletally class 1. At least that's in their intent. Okay? So in their mind, bone is flexible. Bone is something I can manipulate. Okay? And that's how they, in a way, justify, don't worry about the bone too much. It will follow my teeth. But the problem is there's only so much bone can do for that. And especially when it comes to restorative dentistry phase, we don't have the ability to truly rearrange the bone in that sense. These days, a lot of orthodontists, you go to CE classes, they're going to talk about adult orthodontics and expansion of the jaw. Be careful with that because they can only modify so much. You can run into trouble with tilting of the teeth too much, or if you're really in trouble, you're going to move the teeth right out of the socket. You're going to thin out the bone on the buccal or the lingual, and you're going to lose all the bone support. So be careful about that. Okay. But one thing that I thought that was, I want to take one step further. So here is the thing. Dawson says we have to understand, classify occlusion not based on just the teeth, but as it relates to the condyle, entire bone. I wholly agree. But I'm going to go one step further. And those of you who have listened to my lectures know where I'm going. And that is, you have to include how the mandible moves. It's not just how mandible relates to the maxilla in stationary CR. What truly matters is in occlusion, because occlusion is not static. Occlusion is important as I'm talking to you all this morning. Occlusion is important as I am chewing. It's not just so that it looks pretty on an articulator. So my definition of occlusal classification includes how the mandible is moving. That has to be part of the comprehensive understanding of occlusion. Okay? So from angles where you're only looking at teeth stuck in maxilla and mandible without understanding of the condyle, Dawson says, no, we have to understand the TMJ condyle. And then I'm going to say, great, but let's understand how it relates to the condyle as it's moving. Okay? And Dawson actually refers to that, talks about that, okay? And I'm going to get to that before I forget. I'm going to talk about, okay, on page 106, on page 106, okay? I'm going to skip the part about orthodontic discussion on the first paragraph because I hope I at least tangentially talked about the second paragraph. Pullinger and colleagues, and Pullinger was a guy from UCLA, okay? So I know where he's coming from, Okay, and before he started doing research on TMJ stuff, he was classically trained as a prosthodontist, so he's a little biased, I guess. It says Pullinger and colleagues observed that occlusal factors do contribute to TMD and cannot be ignored, but they propose that a new definition of normal should include deflective slides of up to 2 millimeter, unilateral tooth contacts in a retruded condylar position, and all angle classification of occlusion. Deflective interferences to complete seating of TMJ may be normal characteristic in most patients. So Pullinger is like saying up to 2 millimeter of deflection should be considered normal. And you know what? Everybody's going to be a little bit different. What I'm going to say is go to next paragraph. It says the concept that a deflective slide from centric relation must be greater than 2 millimeter to cause sign or symptoms is clearly not consistent with what we observe in clinical practice. It is common for deflection of minute proportions to cause sore or sensitive teeth and or mascatory muscle pain. Correction of the minute occlusal interference routinely eliminates the symptoms. It is clear from the literature that many experts do not accept the role of occlusal interference as an important factor in TMD. But it is also clear that research literature cited to document the expert viewpoint is too flawed to be taken seriously. All I'm going to say basically is this. Different people will literature say 1 millimeter, 2 millimeter, this or that. But you have to deal with the patient at hand. Patient at hand. And this is why understanding patients' pre-operative occlusion is helpful. If you notice they have significant slide, but they swear they have no complaints, then you just do your occlusion to fit within that slide. Make sure it does not stand out. Okay? And chances are you're going to be all right. But that's only possible if you have the habit of evaluating their occlusion before you start the prep. Okay. So for example, when I'm doing composite, let's say, because even as a prosthodontist in LA, my patients don't know any difference, so I will do some composite fillings. What I will oftentimes do with composite fillings is, let's say, DO number 19. Before I start removing the decay or previous filling, I will check my occlusion on my tooth. And if I notice there is a lot of lingual interference on number 19, I'll go ahead and I'm going to work on that tooth anyway, right? I'm going to go ahead and get rid of occlusal interference on number 19 first before I do caries control or removal of pre-existing filling. Once I am happy with that occlusal interference reduction, then I'm going to go ahead and do my prep. Because then, when I'm done with my filling and when I equilibrate the occlusion, then I don't have to struggle so much about getting that patient into my CR that I want to do. Just makes it so much easier. Same thing with crown preps. On the tooth that I'm about to do the crown, if there is a significant occlusal interference, don't be in such a hurry to just do the prep. What I'm going to do is I'm going to see what it will take to get rid of the interference. Once I do the interference removal, and then I do my crown prep, you're going to find that your crown prep afterwards becomes far more predictable because, and the reason why I say that is because, especially on second molars, what you oftentimes find is that you do the prep with the reduction that you normally will do. And by the time you make temporary, what happens? There is no room. Why? Because that tooth was in interference. So now you got rid of the reduction, but now you just got out of interference, basically. Does that make sense? Okay. So what you need to do is to make sure that you do that, you discipline yourself to get rid of the interference first before you do the actual prep. If you do it that way, your crown preps, single units at least, and fillings will become far more predictable. And once you become good at it, it doesn't take that much more time. Okay? So that's number one. Number two, when you're doing preps, especially crown preps, your clearance that you're looking for should not be only when they are biting down. Your clearance should be there even in excursive movements. Because in excursive movements, sometimes is such that you don't have enough reduction, then your crown will always be high no matter how much you adjust, unless you want to go too thin, it's in excursives. So classic example is, let's say, if I'm doing number 8 prep, when the patient bites down all the way, I make sure on my lingual there is adequate clearance. But if my patient goes through excursive, the protrusive all the way, and my protrusive, my incisal contact points are almost touching, even after my prep, that means my final restoration will always be too high in excursive. So I want to make sure in my excursive movements that there is adequate clearance. And that's true for both filling and my crown preps. And that is sort of in line with getting rid of the interferences. Because if the teeth were such that after my reduction, if the preps coming almost in contact, then you can almost bet that tooth was in hyperocclusion to begin with. Okay. And this is what I mean by allowing the occlusal classification, the concept of occlusion, to be that of a dynamic, moving mandible, not a static, full, closed occlusion. Okay? I hope that makes sense for you on that. Okay? Okay. Um, So, and this is important, I think, page 110. I hope just to emphasize, maybe I'm being a little insecure myself. Okay. He says on upper left side hand column on page 110, discussion. Two essential skills must be learned to accurately classify occlusion. The skill of proper load testing and the ability to classify TMD into specific structural disorder. Mm, I'm going to say that when he's saying load testing, he means ability to find the true CR. Because basically, according to him, part of finding the true CR, you have to have a load testing. Okay? And for me, that's when the patient is able to clench. Okay? Now, on the fourth paragraph, okay, third paragraph, let's start with the third paragraph. No reliable substitute exists for load testing. However, load testing may be used in combination with anterior deprogramming devices to relax the lateral pterygoid muscles and to separate all posterior teeth contacts. Okay, I'm not going to stay dwelling on that. Next paragraph. Centric relation cannot be verified by unguided closure. Unguided closure can be seriously influenced by muscle incoordination patterns that result from deflective occlusal contacts. Muscle memory patterns guide the mandible around deflective tooth interferences and into a habitual closure into maximal innocuspation that requires displacement of one or both TMJs. Load testing is critical to verify that the joints are completely seated in centric relation. Okay? And so You go like, well, whatever that means. But what I'm going to basically say is this. You guide the patient into CR, and you have to have the ability to be able to clinch. Basically, that's what I mean from a clinical perspective. Okay? And when they're clinching, if they are deviating sideways, not good. If they're coming slightly forward, like I said before, it's probably acceptable. But lateral shift is almost a red flag. It's minimum yellow flag. Coming forward is not red flag most of the times. It's slight yellow flag. Okay. Before I wrap up today, I know I barely made it to the vertical dimension thing, and we're gonna talk. There is a lot of discussion here that I think is critical, but just so that you don't stay too confused too long, I'm gonna give you my summary. Okay, as you're rereading it again, and all of you who have listened to my lecture already knows that what my summary is going to be about vertical dimension. I'm going to lead you to page 121. Left-hand column, one, two, three, four, fifth paragraph. It says, starting with several studies have shown that there is a significant relationship between the power point of muscular contraction and repeatable phonetic and comfort measurements. Using electronic means on dentures, Tuller found an average variation of less than 0.5 millimeter from the vertical dimension established as the muscular power point when compared with either pre-extraction records or phonetic methods. Silverman has reported consistent results in measuring the VDO by phonetic methods. When a patient has lost natural occlusal stops for recording the vertical dimension, we have found that Silverman's closest speaking technique has provided consistently reliable results. The vertical dimension established in this matter is repeatable with extreme accuracy, even over a period of months. So I'm here to tell you, and I say this many, many times in my lectures, your ability to learn phonetic testing is going to be so critical for you to be able to do predictable dentistry. And this phonetic testing comes back again when we talk about envelope of function. And phonetic testing is in line with what I said earlier about understanding occlusion in a dynamic manner. It's an evolution from Angles classification to, to Dawson's incorporation of the TMJ joints, but he primarily spends so much time on static occlusion, but he makes a point of the dynamic nature of phonetics and how it is predictable and accurate. And I don't understand why you spend rest of the book trying to figure out other means when you have something that is this predictable. And he repeatedly, whenever he has chance, he talks about this over and over and over. But the funny thing is, they don't emphasize this over other techniques. Why? Because other techniques are grandfathered in. They've been there all this time. People have hard time breaking away from it. So when I talk about phonetic testing, I'm not talking about something that I invented. No, I learned it from these people. But I picked up on, oh, this is a little jewel that they are trying to hide. Dr. Mylene.
Hi. Yeah, also on page 110, it talks about the ability to classify TMD into specific structural disorders.
Mm-hmm.
Do you think what references good to look at in order to study more about these the TMD specific structural disorders?
Okay, good point. You are always catching me in areas where I take for
Sorry, is that the
granted.
Piper's classification or?
No, at least in Dawson's book, okay, from this book. If you go to page, starting with chapter 24, actually chapter 23, the chapter title is Differential Diagnosis of Temporomandibular Disorder, right? And then chapter 24, Occlusal Muscle Disorders. Chapter 25, Intracapsular Disorders of the TMJ. So they will talk a lot about, how different things are categorized based on all these different things. Okay. And I am going to say that when we get to that, and then chapter 26, classification of intracapsular disorders. Okay.
Oh,
Now,
good. Thank you so much.
yeah. Okay. So, so if you get ahead, you'll be able to satisfy that curiosity there. The reason why I don't dwell on it so much is because, as I said earlier, 95, 98% of your patients, you don't need to say, this is grayscale 7.5. You just need to know it's a different shades of gray because I treat them the same way. If I'm going to treat them the same way, why do I spend exorbitant amount of effort and energy in trying to classify them into 20 different classifications? I'm kind of giving away my perspective on that, but we will be able to look at those minute differentiations of classifications later on. In my practice, I don't actually bother thinking about that way. What I do pay attention to is deviation, initial contact point, deviation. Is it towards the front, towards the left or right? Is it bilaterally supported? Unilateral interference? Is there likelihood of capsular, I'm sorry, disc displacement, derangement, dislocation? I am thinking about that. And if I come to the conclusion it's more than a derangement, meaning the disc is displaced, then I will pay a little bit more attention.
Doc,
Then I, Mhm.
as far as a like an act from an academics discussion, like to give evidence for a reasoning, like your reasoning for treatment. Um, the point is the issue is that in the past they didn't really relate TMD to occlusion. So to justify your treatment, like the problem is they're not really giving a diagnosis around the TMD related to the occlusion to justify occlusal equilibration if patients having symptoms like from a academic standpoint. I mean,
Mhm.
to give evidence of reasoning behind treating, and it keeps saying like you have to classify the TMD.
So I see what you mean. So yeah, from an academic perspective, so if I were to write a letter to my insurance company, let's say if I were to, okay, because they're not interested in covering this anyway. But if I were to, in my past, what I will use the term is I will tell them if it is an internal derangement, joint derangement, or I will tell them suspected unilateral disc displacement with reduction or without reduction. Reduction just means disc is getting back into its position. Okay. Um, but if I wanted to do that, I need to now truly do CT scan and MRI scan to try to visualize that. And as I said, if I'm going to be dealing with teeth when I'm working with my patient, it's very rare that I would actually go that far. You know, I think I've written letters pertaining to that much detail no more than 20 times in my career. I wrote a lot of exam papers about that when I was in my program. Okay. When I'm taking those TMJ courses. Okay. But the reality is when I'm actually dealing with the patients, I really don't have to deal with that. I think 90% of the TMJ joints will be covered with the term internal derangement. It just means that they are not healthy. Okay. Now, when I am doing a rehab of some kind, and the way that I define rehab means I am reinventing their occlusal stop. It does not mean a full mouth rehab. But if I am reinventing their occlusal stop in the posteriors, so it could be it has to involve number of teeth. So it could be classic example of, let's say, would be 18, 19, 20, 21, 28, 29, 30, 31. With those teeth replacements, okay, I am going to I am going to reinvent how their occlusion comes to a posterior stop, right? If I'm doing that, whether I like it or not, I am reinventing their maxillomandibular relationship. I cannot maintain what they have pre-op when I'm doing all those teeth all at once. And they could be teeth or implants. Okay? So to be to get stuck in the pre-op classification, other than to know that it is something that's gonna prevent me from doing my job, to me is, like you said, is an academic exercise. From a clinician's perspective, I don't think that really is that critical. The reason why the academians emphasize that so much is because those academians are usually in the field of orofacial pain. And that's how they make a living. Those people don't do rehabs. If people are doing rehabs, as in general dentists who are doing rehabs or prosthodontists doing rehabs, we don't get stuck in that concept, because by the time we are getting into the rehab portion, we know that our predictability is greatly enhanced if the CR and CO coincide together. And that's always going to be our goal. We don't want to maintain their 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 poorly related maxillomandibular relationships. So it doesn't really matter what the classification is. My end goal is always going to be CRCO slide together with no interference. So that's why where the restorative dentist comes from and orofacial pain specialist comes from is totally different. Because orofacial pain, for I mentioned to you, Pullinger was a TMJ specialist, and he started as a prosthodontist. His entire practice later on in his career, okay, was treating patients with splints. And I have patient who was treated by him, and he tells me he was really happy. He had all these problems. He bounced around many dentists. He was not happy. When he found Pullinger, and Pullinger was able to get rid of all his pain with just splint therapy, he was ecstatic. This is exactly what my patient says. And then the Pullinger says, now go find somebody else who can restore your mouth like that. I mean, God bless him. Yeah. Well, what is the patient supposed to do? He bounced around all these patients who other people couldn't do it. Well, but the splint therapy got him out of pain, but he can't chew with splint therapy, splint in the mouth. So ultimately, at the end, you need somebody who's going to restore with that in mind. So all the definition in the world, they're they're not, in my opinion, it's an academic exercise. It's not a real world exercise when it comes to restorative dentistry. That's why I actually don't emphasize too much when I give my lecture. And maybe that's my weak point too, because I don't pay attention to that as much. I learned it, I'll read it, but I know that when it comes to my patient's mouth, those details don't really matter. Because what I'm looking for is stability in the joint, and I need to restore to that. The joint, here's one more thing. Remember what we said. Joint affects the occlusion, right? We know that. Occlusion also affects the joint, meaning if I give my patient good, stable occlusion in the long run, even though they will still need to be adjusted a little bit, I know that their joint becomes more stable. So if somebody came to me with a disc that was prone to displacements, hopefully when I'm done with them at the end and after a few years, they no longer have that diagnosis applicable to them because their joint will be more stable. So to me, the diagnosis is only for their pre-op or only if they stay with splint. By the time I cross the line into restorative dentistry, that diagnosis probably will not be applicable after I'm done with my restorative restorations or definitely after a few years. So I hope that was uh, I hope that was a useful discussion today. Okay. Um, Now, one thing that you come to understand now when you are talking about vertical dimension, as a sort of a preview of our talking about, is you're going to understand now when it comes to vertical dimension, it's all about the muscles, right? So until now, Dawson emphasized the structural relationship, the condyle, the bone, the ligaments or whatever. Okay, and he did talk about the muscles, but he didn't really emphasize that, right? Well, now all of a sudden, now when we're talking about vertical dimension and certainly neutral zone and envelope of motion, which is what I'm talking to you about, the movement, dynamic nature of occlusion, it's all about the muscles. Okay, we cannot ignore the muscles. Muscle is basically what is going to make it work or not. And I think at the end, I want to say, yeah, page 128. And I don't think they're trying to be cute here. They're just trying to emphasize 128. Right before the summary on the right-hand column, they quote each other, right? Harry Sicker or Sitcher, he's an MD. I don't know what kind of MD he is. He says, when bone and muscles war, muscle never loses. The muscle's going to win over the bone any day, all the time. And then Pete Dawson says, when teeth and muscles war, muscle never loses either. So that means teeth better learn to make peace with muscle, right? That's what he's saying, right? Your teeth better not piss off the muscle. Well, what dictates muscle? I mean, what aspect of the occlusion does muscle dictate? It's how your teeth move I'm sorry, how your jaw moves. Isn't that kind of contrary to, and I'm going to make a point again, of how he was trying to emphasize about anterior guidance? When they talk about anterior guidance, I want you to pay attention to that. They are implying your teeth are going to control how your jaw moves. It's contradictory. Okay? So I want you to think about the evolution of his thinking. This is why I like his book. Even though there are little things here and there I disagree, I like how he's building up the different components of occlusion. And even if I disagree, I can see how his way of thinking is helping my evolution of my thinking. Okay? We understood about the importance of the disc. We understand the importance about the bone. Now we're going to think about how the bone moves against each other with the muscles. And eventually we're going to now start thinking about how the teeth fit within that space. Your occlusion has to be set up in the patient's mouth in that order. In that order. Unfortunately, with the decades of emphasis on canine guidance, anterior guidance, dentists have been misled from this. Dentists have been led to believe that if you just do anterior guidance, everything will be resolved. Isn't that just the opposite of what we're talking about? Okay? And this is why I hope you will start to see why I am emphasizing, why I approach occlusion the way that I am approaching it. Okay? So I'm sorry again, I always have optimistic goal of getting up to a certain part. When I give you reading assignment, go ahead and read again vertical dimension. We're gonna read neutral zone. I think neutral zone is a relatively easy reading. Okay. Envelope of function you have to think about a little bit, and then functional smile design, and that they are all now interrelated. Okay, and I think it's critical that we think about all this, and it's important that we are able to go back to any of the concepts that we have read as we're going into now more practical clinical dentistry. Okay. So I'm gonna say that even though I told you to read up to page 158, we didn't get to that part. That's okay. Okay, I need to mark. I'm gonna say we're gonna starting next month. We're gonna start with vertical dimension, because this is a critical part. Because if you are gonna ever become restoratively uh, uh, sort of challenging yourself and start doing something equivalent to full mouth or implant prosthesis and things like that, rehab sort of thing, you have to understand vertical dimension. The reason why many dentists' work fail and unpredictable is because they're guessing vertical dimension. Okay. And then so we're gonna start with that, and then we are hopefully my goal will be let's go. If you are able to read, I think it will be helpful to read all the way up to long centric. So chapter 19. So that's going to be 198. I don't think we'll get to that 198 finishing it next time, but they are all related subjects. We're going to go back and forth, back and forth. So your reading assignment will be up to 198 next time. Okay, that will be the goal I have. Do we have any questions? I think you know I feel like after I finish each session, I feel like I'm such a selfish guy because I hog the mic, and all I do is I do talking, and I don't really listen to you too much, and I feel bad. That's not really how I know. Those of you who know me by now, that's not how I normally communicate, right? When I talk to you, I usually like to listen to you at least as much. But this session is set up in such a way I do most of the talking, and I just feel like somehow I failed to do that. So I hope you forgive me on that. I'm gonna restart.